booths up in the front hall talking about it, and try to get the word out once a year during this month. So that's what part of the reason I'm here today, to talk a little bit more about colon cancer screening. So what are we talking about with colon cancer screening now? We're talking about that digestive tract, but mostly just the colon and the rectum. So a typical meal goes through the stomach. It's all begun with you guys here at lunch, churning, beginning to get digested in the stomach for, half an hour or so. Then it's moving along into the small bowel. Really, most of your digestion, and I hate to say the important stuff, takes place in your small bowel. It's about 20 feet, all just along to about 20 feet of intestine. And that's really where all your digestion and absorption, the real important stuff is. You can't live without your small bowel. After an hour or two, maybe even a little longer, what's left over starts entering the colon, and that's where I come in. It starts entering the colon. It can be in the colon for anywhere from a few hours to a few days. Everybody's a little bit different. And mostly what the colon is doing is reabsorbing fluid, storing stool. It's about 4 to 5 feet long. It starts over here near where your appendix is, where the small bowel connects there. It comes up and across your abdomen, and then down into this portion, and then this is called your rectum. It's really just the last portion of your colon. We oftentimes refer to colon cancer screening, colorectal, colon cancer, colorectal screening, colorectal surgeries. Those are all one thing in that the colon is all through this area, and the rectum is just the last 6 inches. But for all intents and purposes, these are essentially the same thing that we're screening for. Treatments are very similar, and they're synonymous, colon and colorectal. Any questions about that? Please interrupt me if you have any questions as we go along. Some of the initial statistics, epidemiology of colorectal cancer here in the United States. It's the second leading cause of cancer-related deaths in the United States. It's the third most common cancer in men and women in the United States. That's one of the things about colon cancer. If you think about breast cancer, prostate cancer, they're specific to one either men or women. But colorectal cancer literally affects men and women pretty so you can see it, and that broadens the number of people who are impacted by it. It's one of the reasons it's so high in terms of the cause of mortality and incidence here in the United States. An estimated 35,000 cases expected to be diagnosed in the United States. This is probably a couple years old, but those are roughly the numbers, and an estimated 50,000 deaths are expected to occur. That number's gone down. I looked back 10 years ago, and you can see it, that number decreasing. I'll talk a little bit more about it, but in general, the impetus we've had, as I'm sure you're all aware, in the last 10 to 15 years, there's been a decline in colorectal cancer. Between 2000 and 2013, the incidence has dropped 32%, somewhere in that range, and mortality is about the same, somewhere in the 30 to 35% range. So you're beginning to see the curve come down a little bit. But it's also been a huge effort in the last 10 plus years trying to get people screened. And I think a lot of people are excited about that. I still think, boy, we got a long way to go, and I think I'm a little surprised that we haven't had a bigger impact on it with the amount of effort that's been put in the last 10 to 15 years. Talk about it also being colorectal cancer. It starts as an uncontrolled abnormal cell growth. Other name for this is a polyp. They can look almost like a little wart in the colon. They can be very nondescript. They can be flat, and as they start to grow larger, they can begin to grow up off the wall. They can be on the stalk and be a little more obvious. We'll show you a few pictures of them. They can start as a very subtle, focused area that begins to change just in the wall that are hard to define. This is sort of the progression. This is an important slide in that this is the way these are some of the expected changes that go through. So why do these cells begin to go through these abnormal changes? So the normal tissue, for various reasons, age, oxidative stresses, various stresses and insults to these tissues can lead to changes, and eventually these mutations can occur along the way. And these are ongoing processes where the cells begin to lose their ability to fight off changes and lose the ability to repair themselves. That's one of the main functions, is They're not as effective at repairing themselves. This is a progression. These different mutations, they don't all happen, but this is just a series of them that can happen. And they're important in some of the testing you do as you get it down. So what happens, you go from a normal epithelium or normal lining of the colon to a hyperproliferating or growing epithelium to what we call an early adenoma. So if you hear the term adenoma, we consider that a precancerous type of cell. It doesn't mean it's going to go on to cancer. Sometimes they're small and don't, but they have a propensity to begin to grow into a larger one, have more changes, and eventually become a carcinoma, which is what we were talking about colorectal cancer. So these are sort of the changes that are going on, some of the genetic changes we see, some of the mutations that happen, some of which can be detected, and I'll talk about that later. So you're going from adenomas to intermediate or larger adenomas to a late one where they're now looking more worrisome, they're almost a cancer, and then you begin to have obvious manifestations of what looks like a cancer. And the worst is when it spreads beyond the area of the colon. It can spread there via lymphatics and lymph nodes through the venous system throughout the body. So that's what we're trying to prevent from happening. Well, this progression, as best we can tell, takes upwards of 10 years, which is important. This happened in 2 weeks. We'd never catch it. It's one of the reasons. It's one of the reasons that I like to think of colon cancer is one of those cancers that we think in that way of if we screen for it and we do something about it, do we have an effective test, do we have an effective treatment if we find something? And most of those questions, the answer is yes, we do. But a lot of that has to do with this slow progression. If this happened quickly, we really, you can't screen people every 2 weeks. You can't screen people every year. With a lot of the things we're doing. So the fact that it's slow and you can catch it in some of these early stages, maybe even prevent the progression, or even catch an early colon cancer, it's still very treatable. Surgery is very effective in treating early colon cancers as well. Any questions about that? Sorry, it's sort of a busy slide, but that's just sort of the general, you don't have to remember any of the mutations, but I do for my course. That's what happens in the progression as we go along. And this is sort of a stepwise process that occurs that takes years. This is talking a little bit about what they look like. I talked to you about those early small polyps. They may be wart-like. So this is the inside lining of your colon. So you'd be looking at this in a colonoscopy. It look like just a little bump. And then they can grow up and off the wall, and they can have a stalk and be a little bit grown up. And that's a polyp on a truncated stalk. And then as they outgrow that and they can grow into the wall and spread through the wall, then you're talking about early cancer, what we call an adenocarcinoma. These are just what they look like colonoscopically, small polyp, pedunculated, a little bit bigger one, probably intermediate to a little larger size. And that's, as you can see, that's a cancer that's irregular. It's around the whole wall. This is all abnormal tissue. That's normal tissue there. That's what they look like. Different types of colon cancer. Sporadic is the most common, meaning it can just happen out of nowhere. There's no warning, there's no risk factor, there's no expectation that was going to happen. The majority of colon cancers that we see in the United States are that. It's one of the reasons we sort of recommend universal screening for the whole population, because so many of our colon cancers are sporadic. Higher risk groups are here. There's some familial ones. You've had family members, brothers and sisters, parents who've had colon cancer. Risk factors start going up. Hereditary, if there are a series of family members and we've identified the gene, there are a couple of hereditary conditions that predispose you highly to colon cancer. We keep a close eye on those people. And then the last one here is IBD, inflammatory bowel disease, which is Crohn's disease and ulcerative colitis. Patients we take care of in our practice. Just that constant chronic inflammation in their colon raises their risk a little bit for colon cancer. So we actually keep a close eye on them during the duration that they have the Crohn's disease or ulcerative colitis. Some of the risk factors for colon cancer. I'll start with the lifestyle ones, because a lot of them are lifestyle risks. Diet seems to be a big one. I always think of colon cancer as a first world disease. We screen for it, we watch for it here in the U.S., Australia, Europe, first world countries tend to be where you tend to see colon cancer. Asia, Africa, areas like that, you don't tend to see as much. Some of that we think has to do with diet. It's difficult to pinpoint these things, but it seems to be some of the correlates we've seen are high diets in red meat, and processed meats or foods, cooking meats such as grilling, talking about whether the grilling of meat may cause nitrates to form and be more problematic. So a lot of it seems to be diet related, physical inactivity, obesity, smoking, alcohol use, all of the sort of first world dietary lifestyle things that we battle with a lot of these. These all seem to be general risk factors of colon cancer. As you can imagine, it's difficult with the diet and some of the other lifestyle things, but in particular the diet, trying to pinpoint. People always ask me, what should I eat, what should I not eat? I usually tell them a few things like this, but in general I say, eat a healthy diet. We eat too much meat, we eat too much processed food, eat more fruits and vegetables, try to have a more balanced diet. These studies are very hard to do. You have to do them over decades to try to figure out whether there's something in a particular population's diet that brings it. So I don't think we're ever going to come up with a single thing or a few things. It's a general sort of dietary recommendation that we make for this. Other risk factors, as we mentioned, you start getting a higher risk for colon cancer just by being a little bit older. You start screening at the age of 50. There's a reason for that. Our risk all starts going up at that point. Personal history of colon cancer or polyps. So people who've had a colon cancer already, we monitor them closely because there's a higher chance of a recurrence or a new cancer in them, so we keep a close eye on them. I mentioned already inflammatory bowel disease. I won't get into detail. Family history, parents and brothers and sisters who had colon cancer or advanced polyps, that will raise our concern, and we'll keep a close eye on patients. We'll recommend closer follow-up. Inherited syndromes, and certain ethnic and racial backgrounds. African American, we don't appreciate it's mentioned in this country, this state, but they should be screened earlier, probably at the age of 45. They are more risk for colon cancer, tends to be a little bit earlier. We recommend that in general African Americans begin getting screened at 45. Certain Jewish populations, Ashkenazi, Eastern European, Mediterranean descent. Some certain populations of Jewish ancestry should screen them. Oftentimes that goes along with family members who've already had colon cancer, that's sort of a trigger that we know they're at risk. So this is our title today, the ick factor. This is, I thought I'd mention a little bit of the ick factor. I'm proud that you all came out here at lunchtime and talked about it. So you're over the ick factor. I get away from it because I don't think I talk about this all day long. So, but it's, it is an uncomfortable topic. It's something people don't want to talk about. They don't want to talk about, whether they're having changes in their bowels, whether they're seeing bleeding, those types of things. They don't want to go through uncomfortable tests, potentially uncomfortable tests, if they're feeling okay. They don't want to talk about it. I think that's probably the biggest reason people don't get screened. They don't want to talk about it, or the physician hasn't brought it up and doesn't want to talk about it. That conversation doesn't happen. And that's where we have to sort of get over this ick factor. Trying to get people comfortable with the fear of getting tested. I don't think it's so much of an issue here, but some people think of it as colon cancer as a man's disease. As I talked before, it's pretty equally spread between men and women. Women can get it just as easily. And once again, no symptoms, so what's there to worry about? Some of the signs and symptoms we worry about. Once again, we tend to have no symptoms, but they could include. And these are usually when you're talking about signs and symptoms. These are that progression I was showing you. That's getting towards the end of it. That's as the cancers are forming. This is when we begin to start having symptoms, and that's why we need to react to those quickly, because you can find these early cancers and treat them. You don't want to let them go on. It's tough. Changing bowel habits. It's a fairly subtle indicator, but if you haven't been screened, it's one of the triggers we say we better take a look or do some testing or at least do some screening. Feeling of medium movable bowel movement is less likely, but that's if you have a low cancer. It can give you that type of sensation. Rectal bleeding is probably the most common indication. We have people that, have not had issues, and then all of a sudden they start seeing some blood mixed in their stool or the toilet paper. It's not clearly hemorrhoidal. That's when we worry about it. We make sure we get a look, or at least work them up at that point. Blood in the stool which look dark. That can indicate any kind of GI bleeding. People will get sent to us for that in many situations. Cramping or abdominal pain, once again, recurring, ongoing, not something that just comes and goes, but something that's sort of established itself. You start worrying about that. Weakness and fatigue and unintended weight loss. So those are worrisome signs where people begin to get anemic from that blood loss. And the blood loss can be silent. You cannot see it and develop an anemia, and that's a common indication for us to be able to we'll screen people if they've had unexplained anemia. Those are some of the systemic signs I'll have with that. Questions about any of that? So who should be screened? Talked a little bit about average risk people. Here in the U.S., it's recommended everybody 50 to 75 average risk. So once you hit 50, just because you hit 50, you should start getting screened. After age 75, the benefits begin to wane a little bit. So a lot of that is sort of a one-on-one discussion. Depends on how healthy you are, when you had your last screening, what kind of risk factors you have, that kind of thing. How long your parents had lived, those types of conversations. Men and women, people at high risk. We'll talk a little bit more about the risk factors as we get into it. They have to be screened a little more often and regular, so oftentimes we'll shorten that interval to colonoscopy every 5 years. In general, we tend to screen high-risk individuals with colonoscopy, and family personal polyps or colorectal cancer. So we've been screened, we know you have precancerous polyps. We keep a closer eye on it, maybe a 5-year follow-up in terms of following up that. That's all sort of colonoscopic related, but once you get into the high-risk category, you're sort of being shunted into the colonoscopic screening method. So we mentioned 50-year-olds, no family history, less than 50, don't need screening yet. As you get into people over 50 with no family history, average screening, they should be screened. And then the reason I like this slide is it tells us a little bit more about what the family history is. We talked about the genetic or inherited mechanisms. These are just abbreviations for what a couple of those are. These are high-risk people that get referred to us, and we keep a close eye on them at a young age. And they'll probably get, if they haven't seen a genetic counselor, we'll oftentimes get them involved with the genetic counselors here in town. The nice thing about that is once you have somebody who's had an identified genetic alteration, then you sort of know for that family what it is to follow. You don't need to keep scanning everybody, but you can look for those particular gene mutations in the family, in the affected family members. We'll talk about what raises your risk in terms of family history. Two or more first-degree family members, so brother, sister, parent at any age, so over the age of 60, or probably the one that's more indicative is any family member who's had it at an age less than 60. Once again, brother, parent, that sort of thing, child, anybody who had colon cancer in less than 60. And that can begin at age 40, and they get colonoscopy every 5 years. So this is yet again another busy slide. There are lots of organizations who have recommendations on how you should screen, what's endorsed or approved to screen. The one I put up here was the U.S. Preventative Task Force, U.S. Preventative Services Task Force. These are their recommendations. I think they're the most conservative. I think they're very good, and in general, we tend to follow these. Things have gone on and off this list in terms of what they recommend for screening and not. But this gives you a rough idea as to what are different options for people for screening. And we'll spend a little bit of time here talking about these different screening options. So the first one here is what we call fecal blood test. So that is, you may have had these over the years, where you turn in a stool card, oftentimes 3 little samples. You can mail them in, and you check for microscopic blood. So that's with the occult blood. We're looking for microscopic blood in your stool, and it's actually a peroxidized test to pick up on hemoglobin, heme within your stool. The thought is, as polyps grow up and they begin to turn into advanced polyps, and even more so into colon cancers, they begin to outgrow their blood supply. They're friable. They're not normal tissue. They begin to ooze and bleed a little bit. It's one of the reasons people oftentimes present with anemia when they've got colon cancer. So as they get more advanced, they begin to have a little bit of bleeding, and that can be microscopic, and we're trying to pick up on that with the fecal occult blood test. If you decide to do that with your physician, the important thing there is you got to do it every year. Along that spectrum of polyp on colon cancer, we're trying to pick up something on the end, of the tail end of that progression. So you can't go every 5 years or every 10 years with just a fecal card. You need to stay after it. That's probably the toughest part of it. It's an easy test. You send it in. You don't need to do any prep. It's a straightforward test. The problem is you got to stay after it. You got to do it every year and decide that's the way you want to screen going forward. There is some benefit in terms of mortality, and which is why it's on this listing as a recommended test from the preventative task force. FIT test is probably the better stool-based test. These first 3 are stool-based tests. The FIT test is it's an immunochemical test. You don't need to know the details, but it's a single stool specimen, small sample you send in, and that is checked. It's a little more accurate, a little more sensitive and specific than the fecal occult blood test. We're picking up, but still not good enough. You're still trying to pick up that late-term bleeding lesion, so it's still recommended that you do it every year. So it's a little better test than the fecal occult blood test. I think the fecal occult blood test is still out there. There's so much data was generated by that. There's clearly been some benefit. I think it's good data, but I think you're seeing that the FIT test is just that much better. So most people have switched over to FIT testing now. And then FIT DNA, it's a combination. So you're both looking for blood or hemoglobin in the stool sample, but now you're also looking for some of those genetic markers. That progression I showed you, we can actually identify some of those genetic markers. So these cells within your colon, normal cells as well as abnormal cells, are always shedding a little bit of the cells, and this is a mechanism. Another name for this is Cologuard. You probably heard the ads on the news, but it's basically, and they're trying to pick up on these shed cells, these abnormal cells that they can now detect. And they're also looking for microscopic blood as well. So that's actually looking a little bit further, spreading out and looking up a little further up that progression. So you're not at the end stage of a colon cancer or something that just has to be bleeding. It may be just an advanced adenoma or something further up. So that recommendation is actually probably even go out to 3 years for that. And do that stool sample probably every 3 years. Once again, like the other 2, you don't want to do that every 10 years. It's one of those things that you decide that you have to stay after it and be diligent about doing it. Questions about those? So that's Cologuard, the one that's sort of been in the media lately. Just got approved. It's been approved by the FDA for 3 years. It was just adopted by the USPTCF in the last year or 2. And then the next one, which I think a lot of people are familiar with, are direct visualization. There are a couple of different ways of doing that. Sigmoidoscopy is the way we used to do it. And still in some areas we do. It's sort of a limited scope of the left side of the colon every 5 years, looking for polyps or any abnormalities, picking up on potential tumors there. But also, I think more importantly, trying to pick up on any polyps that might indicate that, oh, you're making polyps, we got to look at the whole colon. Colonoscopy, I think everybody is familiar with. I spend a good portion of my day doing those. Recommended every 10 years, trying to get a good look through the whole colon, both for polyps and for colon cancer. And then last combination, some people can do flexible sigmoidoscopy every 5, alternating with FIT tests in between. either of any of those. So sigmoidoscopy being abnormal, CT colonography, which I'll talk a little bit about, that's the newest one in the last 5 years or so, which is made it onto this list as a way of screening, is a way of CT scan imaging the whole colon and looking. All of these, I'll point out, these fecal occult blood tests, fit testing, the DNA testing for stool, CT colonography, all of these, if they end up being positive, they end up feeding into colonoscopy because it can be both diagnostic and therapeutic. So if you need to sample tissue or you need to remove polyps, they all sort of diverge into colonoscopy if they end up being positive. So I talked a little bit about the advantages of stool blood testing, those first three. Less expensive, offered by any member of the healthcare team, so your primary care can offer it. We give them out to patients. You get the package you just take home and you mail it back in. No bowel prep, so there's nothing involved. Done at home, doesn't require time off from work or systems getting home after a procedure. It's non-invasive and no risk of causing pain, bleeding, bowel perforation, or other items. Talk a little bit about these options. Fits, like I said, the FIT test has really been replacing fecal occult blood tests. It's really a better test if we're going to do that at all. My guess is the Cologuard, at least from a screening standpoint, it will begin to probably displace FIT testing. The thing is, with FIT testing, sometimes we'll do that. We're just looking for bleeding in general, not necessarily just for colon cancer screening. So there's uses outside of colon cancer screening. Here's some of the pros and cons of the FIT testing. Once again, direct measure of hemoglobin in the stool. It's an annual test. No direct risk of colon. It's inexpensive. No time off of work. It's 80% sensitive for detecting cancer. So once again, like I said, you're trying to detect that stuff at the end stage before it gets to be advanced, but catching it as an early cancer, that's the ideal. That's what you hope. If you get lucky though, it's also 20-30% sensitive for detecting advanced neoplasia, really pointing towards advanced polyps that are just becoming cancers. Cons, it can miss some polyps and cancers. It's got poor sensitivity for these types of polyps that we're beginning to recognize called sessile serrated polyps. Probably in the last 5 to 8 years, we've been identifying these as sort of a subtype of polyps that we've been finding. They can still progress to adenocarcinoma, and they act a little bit differently. And so these are not as good for picking up on those. And as I mentioned, positive fits or any stool-based test leads to a colonoscopy. And once again, you need to do the fits here. Talked a little bit about the Cologuard or fecal DNA testing. You're looking for advanced adenoma or carcinoma cells containing altered DNA that's always being shed. That's what you're trying to pick up. You're trying to detect. One of the tricks is, and I don't know the mechanism, but the company's come up with a way of isolating that from all the other DNA that's in your stool. Bacterial, but they've been able to identify these markers. And that's really the key to this test, of being able to find these human markers that are an indicator that there are precancerous changes going on. There's no single mutation, so there's a whole series that these mutations are looking for. It's multi-targeted, about 87% specific, and sensitivity is getting higher and higher. So, questions about that? Sir?
I just say the DNA is altered.
Yes, so begin to show some of those manifestations. So some, as a best example, some of those cells may be beginning to lose some of those abilities to repair themselves. And some of those are identified as gene mutations, where you've had an alteration, and all of a sudden it's an indicator that your cells can't repair as well as they used to. And that's an indicator that your risk for colon cancer is going up. That's one example. There are a whole series of them that they're looking for, and there's an algorithm as to which ones they're finding and which are important for this.
Insurance companies?
They do. Not all, but there are more. And Medicare does now, so that's all growing as you. So it gets approved by the FDA. It looks like it's a good test, and then it's got to be evaluated by these organizations. These American Cancer Society, their various GI societies. They all come up with their guidelines as what they think should be acceptable for colon cancer screening. I use the Preventive Task Force. Just in this one, I think it's the oldest. I think it's the most comprehensive. It's not as it's probably not. It's not as biased, but I think they're a little more rigid in terms of what they accept. So that's when they say that they approve it. I think it needs to be taken seriously. But some of the payers are slow in doing that. So not everybody is, but more and more are. Medicare is covering Cologuard, so that's growing. That's part of the reason you're hearing the ads out there, and as insurers are beginning to pick up and cover it. And that's sort of how the series, that general trend goes with these tests and the approval process.
And all the DNA is just in the stool, or is it out of?
Well, it's on the wall, but it's being shed by the cells. So it's being shed by these polyps or these early cancers or these tumor cells, and they're being detected by this test. Yeah. But it's fairly late in the progression, so that's why you need to do it every couple of years. You need to check every couple of years. Sorry?
It doesn't go to that DNA.
It shouldn't, if it's early enough, it shouldn't be spilling into the blood. But you're right. So what you're trying to do is get it before that's really communicating with the blood. So.
I assume that in this fecal blood testing, that if one finds blood in stool,
Yes.
there's a way to differentiate that blood coming from polyp, coming from the source.
Yeah, well, and it's one of the problems with just checking for blood, because a lot of things can trigger, hemorrhoids can trigger a positive. It's a matter of how sensitive and specific that test is, and how sensitive you want to be to pick up on the smallest amount of hemoglobin. But hemorrhoids can be, little gastritis can lead to a positive test. Lots of things. So I will do a colonoscopy to follow up a positive fecal occult test or a FIT test, and it'll look relatively normal. There may be a small polyp, but to be honest, that's probably not the cause of this small amount of bleeding, because they really, the thought is they don't really start bleeding until they've grown and they've gotten bigger or gotten pretty advanced or even a cancer. But that said, it's probably hemorrhoids oftentimes in that situation, so there's a fair number of false positives in that world that we follow up.
So you follow up with colonoscopy.
Yeah, so if you have a positive FIT, you have a positive Cologuard, those trigger a colonoscopy. You have a suspicious CT colonography, all of those trigger a colonoscopy. So, does that help? As we were approved, FDA approved the Cologuard DNA testing in 2014, endorsed in 2016 by the U.S. Preventive Services Task Force, covered by Medicare as well as other. But that's usually the big kahuna. Is once they say yes, Nick.
I think Medicare actually approved it soon after the FDA, and then the U.S. Preventive dragged their feet.
Maybe out of sync,
yeah.
But that's always the important one, is that Medicare covers it, and other insurers are picking it up. And like I said, there'll be certain organizations that endorse and don't yet endorse certain tests. That first one I showed you, the big sheet with all the different variant enemas come off of it. We used to think variant enema was an acceptable screening method. We've I think lost our skill to read variant enemas. We don't do them as often. Radiologists are not as skilled at it. They've actually pulled that off, and it's sort of shifted over to CT colonography. They're actually better at doing that than variant enemas. So direct visualization tests. Talk a little bit about, I won't go into flexible sigmoidoscopy so much, or variant enema, because that's come off the list, but we'll talk a little bit about CT colonography and colonoscopy. It's still the gold standard. They all feed into this, if anything's positive. But the main reason is they're quite sensitive and specific, but I think more so can sample tissue, you can remove polyps, you can potentially remove polyps that can cause problems down the line. I think that's the real difference with a lot of them. Sometimes we get lucky and you get an early cancer and a polyp, and we're able to treat it therapeutically that way. But so average risk patient with no polyps is recommended every 10 years. So once again, you're seeing the whole spectrum, small polyps to early cancers or even advanced polyps. On that first one, people or somebody who makes precancerous polyps, you end up coming back earlier because of that. But if nothing is found, let's say in your early 50s, and it looks fine, it's recommended that you're probably okay for 10 years, mostly because of that progression slope. We still find some of these still show up in 5 to 7 years. We don't know if they're fast growing, if they got missed. That happens, there's no doubt about it. But all of these tests have fallibility. There are false positives that we're looking at with colonoscopy. Things are missed in colonoscopy. Some tumors are aberrant and grow faster in that 10 to 12 year lifespan. But in general, the recommendations are if you have a clean, normal colonoscopy and average risk, you should be good for 10 years.
Are all polyps considered precancerous?
No. So there are a whole slew of them. Those sessile serrated polyps are sort of newly recognized. They seem to be in that adenoma category, the adenoma, which is a precancerous. Hyperplastic, which we find a lot of, are not necessarily thought to be cancer, so we may find a handful of hyperplastic polyps. They tend to be small.
So do you leave those, or do you still?
And hyperplastic or not. So you may have polyps, they may be hyperplastic or inflammatory, but you're not at any increased risk for colon cancer. And that's sort of where it gets into the subtlety. And that's where we have to sort of dig and find out what kind of polyps you've had before. Adenomatous polyps, yes. The ones we really worry about are somebody, if we find large adenomatous polyps, what we consider over a centimeter. It's tough, and I'll talk a little bit about it with the CT colonography in terms of what you can pick up. So doing colonoscopies, we pick up a lot of little stuff. We pick up a lot of small adenomas, and way more than would ever turn into cancers for people. So we take out a lot of little stuff that may never cause any problem. What we're really looking for is the larger stuff that's acting like so. A small adenoma is probably at a fairly low chance of becoming a cancer down the line. A medium-sized or large adenoma, they're acting like they want to become a cancer. So those are the higher risk ones that are progressing, and those are the ones we really want to go after, if that makes sense. So size, number, and the type of polyp is really the things we're looking at all the time, and weighing and trying to figure out how worried we are about it. Disadvantages of colonoscopy. As you all know, there's prep involved, there's risk for sedation, complications like bleeding and perforation, and lesions can still be missed. I think sensitivity is up in the low 90s, but things can be missed. The quoted colonic perforation risk about 4 in 10,000. So we do a lot of things without a lot of big complications. There can be some small bleeding risks. Mostly that's from taking out polyps and that sort of thing. But those are pretty low risk when you're having to express them in terms of 10,000.
Any improvements coming in with the preparation time?
We're always working on that, and we've gone back to the large gallon thing because it just gives the best prep. It's this balancing act because the prep is so important. If you can't see well, it's going to be, your risk of missing stuff goes up. And so we're always doing this balancing act of, was it a good enough prep, or is this a good enough exam? So yeah, it's always being tweaked. And I think we've got some good combinations, spreading it out, where you do part of it one day, part of it in the morning before you come in. Some of those things make it easier. But you're right, we have not made a lot of progress in the last 10 years. I know it myself. Good. Questions about that?
When you see an adenoma on the chest, no matter what size you want,
So we can't tell when we look. So if it's looking like it's grown and it's gotten fairly big, the chances are it's an adenoma and it's growing to be like that. It's odd to see a hyperplastic polyp this large. But when they're small and on the wall, oftentimes they're hyperplastic and you can't necessarily tell by just looking at it. We have a rough idea by looking at them and getting a sense for them, but you can't by just looking at it, say, oh, that's an adenoma, or oh, that's a hypoplastic, I can leave it alone. We take just about all of them out, and then they get sent out to pathology, and then we get a report back, within a week or so, and we can figure out if they are the different types, are they precancerous or not, something to worry about or not. So that's sort of the process that goes on with that. But these small ones, you can't tell necessarily by just looking at them. So this is just sort of the method of it. That's the end of the scope. There's a video camera, very high quality, high def lens we have. There's a high powered light there. It's sort of like going through this tunnel. And then a channel which we can put air in, we can put liquid in, we can squirt water in, we can put different devices, biopsy forceps, snares, different devices we need to use, little baskets, all kinds of things we can put down that little channel. And it's only about the diameter of, a little bit bigger than my little finger. It's about 10 millimeters broad. So this is just showing where we go through. This is the rectum up through the left colon across the transverse into the right colon. A sigmoidoscopy goes up to about here. So you see the rectum and the sigmoid up into here, and that's about as far as the sigmoidoscopy goes. The same technology, same idea. You're not prepped, and you don't go quite as far as you do with colonoscopy. And that's what it looks like on the inside. Just want to at least show you the technique of polypectomy. That's what they look like in there. When you're trying to get down underneath the polyp, as some of these polyps grow up, and these are the easier ones to take off, the pedunculated ones where they have a stalk. This is actually normal tissue here, so you're getting down on a normal tissue, and you're cutting through it, and leaving some normal tissue, but then trying to get the whole polyp out. As you can imagine, you're cutting through blood vessels there, you cauterize them, but you can have some bleeding, that sort of thing afterwards. So a little bit of the advantages and limitations of colonoscopy, detecting greater than 90% of polyps in cancer. As I mentioned, it provides diagnosis and therapy, taking out polyps. And Medicare covers average risk. Limitations are the risks we talked about, the availability. I don't think it's such a problem in our community, but in certain communities, the availability for it, you may not be able to get it done. Cost, it's more expensive than most of the other tests. CT colonography is sort of in the category, but much more expensive than the yearly or the every 3-year stool testing. And compliance. Once again, getting back to that big factor. He said, oh, sure, I'll be sure to get that scheduled. You tell that to your regular physician. And then it just, somehow you get busy and don't get it scheduled. We talked a little bit about CT colonography. So this is a technique of imaging. It's sort of taken the place of barium enema. It's a way of imaging the colon. It's been endorsed and approved in the last 10 years. Various societies have different recommendations about it, but it's been, I think, widely accepted as a reasonable way for screening. It still involves a bowel prep, so you have to do a bowel prep like a colonoscopy. You come in and you get air insufflated to help distend the colon, and then you get a CT scan. That's basically the nature of it, but it's sort of a high-tech, two-angled CT scan, and it's sort of an elaborate mechanism they use to process those images to get a look as to whether there are polyps within the colon. And so this you can actually you can see them. They can actually look a little bit like polyps on the CT. And these are the sort of reproduced or rendered images they can come up with, almost like you're making your way through it. So it uses a lot of computer power with these CT scanners, but they're pretty good. They're pretty accurate. In terms of colonoscopy, you're talking about sensitivity and specificity, in the 90 range. CT colonoscopy, also in that range, sort of 85 to 90 range. So it's comparable to colonoscopy. The only thing I'd point out here is a little bit odd. You begin to lose your sensitivity and your ability to pick up on things, as you might imagine, with CT colonography with smaller things. So this is all talking about lesions that are bigger than 10 millimeters, sensitivity for less than 6. it begins to drop off as they get smaller. Once again, we don't know what those small things mean. We take a lot of them out. Some of them may be a problem later on. We see a lot of them in colonoscopy, and they're not as important, but some of them can be. So that's sort of what you're trading in a little bit. More?
Is this the technique which is also known as virtual
Yes.
colonoscopy?
So another term is virtual colonoscopy, CT colonography.
Because it has a very attractive sound to it. But
Sounds very high tech.
I'm really wondering how this fits in because, as you pointed out, first of all, you cannot obtain any tissue with this technique.
Right.
And secondly, there's this bugaboo called radiation exposure. How much radiation
A fair
does this
amount.
generate?
They get a fair amount. Yeah, it's
So
more than,
why
more
would
than
you
standard CT.
why would you want to do this instead of the standard colonoscopy?
Just not wanting to take the risk of sedation
Sounds
or
good.
just the whole, it's a fair amount of, there's prep, and as you probably know, the biggest complaint is the prep they have to do the day ahead of time. You still end up quoting this. Right, you still do that for this. Sometimes we can't complete the colonoscopy, or they have a contraindication for, let's say, sedation, and just somebody you don't think they can be sedated for whatever reason, cardiopulmonary wise, whatever. CT colonography may be a way to go, or an incomplete exam may be a way to go.
Can you use an MRI instead of CT and thereby eliminate the radiation exposure?
Not yet. Not yet. Yeah. So.
I think insufflation would be the number.
And it's unsedated. So, once again, that is one of the complaints of it, but it's one of the complaints of colonoscopy too. And usually it's not too bad. They don't need sedation for it. It's been available for 10 years or so plus. It hasn't been widely adopted a lot for the reasons you're bringing up. You still have to do the prep, and if it's positive, you get set up for the colonoscopy. It's sort of this close to having a colonoscopy. That's the main reason.
If the second one has radiation implications, I hope that you would not recommend it for someone who's already had radiation in pelvic area.
I would agree.
Because
Yep.
you're already struggling with challenges enough. You certainly don't need to.
No, and that's why I think when you have all of these options, you got to have a conversation as to with your patients to what you're comfortable with, what your risks are, what your history is, and should be going this way. But I bring this up. It hasn't been widely adopted, but it's it's on all the recommendation. It's a pretty darn good test.
Rob, do you have any idea today how many screening colonoscopies are done in our community? Do you have any rough number today?
In our community, I can't tell you how many screenings are done.
Total colonoscopy.
I would say, total colonoscopies in the 7,000 to 9,000 range.
That high?
Something like that, somewhere in that range. And I would bet over 50% of them, maybe 60%. You know as well. 50 to 60% are screening.
It was about the time you came here that we actually, your polypectomy picture made me think of this.
Yeah.
You have to realize that a screening colonoscopy is about one of the only screening tests you can actually get cured of cancer while you have the test. So if you have that polypectomy and you happen to have the cancer in the top of that polyp and it doesn't go to the base, there's nobody saying you need any further surgery or anything else. And I was curious, we were curious, both the GI group, and we looked up, I can't remember, it was a total number of screening I think we had, but I think it was like 3,000 then. And there were about 8 to 10 per year of patients cured. Now, we got that data from the path department by looking at the polyps. They tracked it, and it was like 1 year it was 5, 1 year it was 8.
Didn't need
So it's a
surgery.
pretty small number, but it's pretty nice if you're going to have cancer to have it cured during your screening test.
Yeah.
It's a rare thing, but it is interesting.
Yeah, well, and I think what Nick's alluding to is you get these polyps that grow up and they're on the stalk, but
Right.
within them, there's just a focus, a little focus of cancer, but you got the whole thing out. So they're a very, very early cancer, and you just got lucky and you were able to get it out.
It's pretty easy to have that study done because the pathology department can treat, if you tell them in advance, they can look at that. It might be fun to look at again and see what those numbers
Yeah, no,
are.
I agree. But I think it's become so widespread now, and so many of these screenings are not initial screenings we're seeing. I think a lot of the numbers you were talking about then, those were mostly initial screenings,
That's
where
right.
now lots of people are coming back for their 10-year follow-ups. Those are still screenings, but they're now in the queue. So I think that's probably why the number's grown as much as anything. I'm going to finish up a little bit with just some recent screening initiatives we've had. 80% by 2018, screening navigators, which is sort of particular to New Hampshire, and FluFit. Once again, public health initiatives to try and get increase the number of screening in different ways. 80% by 2018 initiative is just trying, it's multidisciplinary, a bunch of different groups come out, trying to get everybody screened by the year 2018. We're not quite there, but these numbers have really increased over the years. We look back to the Katie Couric effect and all these colon cancer screening awareness programs that have been going on for 10 years. This is 15 years ago, something you didn't really even talk about. So, you know, the TV anchors having their colonoscopy on early morning TV, it makes an impact on people. So there was all of this build up. We got our numbers up close to 80% within this community. Big effort with Joel Berman going to Centricity and electronic medical record. They were able to monitor and get a better sense and try to send reminders to docs to say, don't forget to bring this up with your patients. And we got numbers close up to 80. I want to say here in New Hampshire, the screening rate's low 70s, 70, 72 right now statewide. We've sort of dipped back a little bit, but I think we're sort of getting geared up to get people active about it. So this is a nationwide 80% by 2018. 15 years ago, we were at the 40 to 50% rate nationwide. We weren't doing it at all. So lots of organization, multidisciplinary. American Cancer Society, all kinds of primary care organizations. A lot of groups involved trying to get this pushed forward. I wanted to just talk a little bit about the patient navigation model. And this is really trying to reach out to hard-to-reach populations. So you can imagine there's some of that 20% is just going to be really hard to get in from socioeconomic standpoints, from just health standpoints. It's going to be hard to get them screened. This was a program actually developed through the New Hampshire Colorectal Cancer Screening Program, where there was an NIH grant, we had funding. The gist of it was you had a navigator who was very intensive about calling the patient, making sure their PrEP medication was at their pharmacy or they were getting it and knew how to take it. It was a lot of education over the phone. It was quite intensive, but also very effective to the point where they could actually have patients who were homeless and get them prepped and in for a colonoscopy and a ride. And it was they had 2,300, 2,400 patients, and about 2 or 3 no-shows for colonoscopy. So it was pretty impressive. That program remained in place, but the funding for colonoscopy went by the wayside with Obamacare, because it was expected that everybody had at least coverage for colon cancer screening. But it's still in place, but I think it was a nice snapshot of what can be done with intensive navigation type of support through primary cares within the community. I think it's sort of a window on what ACOs may look like, and the home health method and all that sort of thing in terms of intensive nurse navigation, that kind of thing. Any questions about that? The patients were very satisfied with it. And even if they were found to have something on their colonoscopy, that navigator helped them get through treatment, connected with oncology, general surgery, made sure they were at appointments. It was fairly impressive. Eliminate some of the barriers. The patient navigators were very involved in the FHAQs, the family health centers throughout the state. That was a big part. So if there were language barriers, that sort of thing, they were helpful with all of that. FluFit is it's been if you decide to do fit testing as your way of screening, just a reminder every year you got to get your flu shot and you got to get your fit cards. So it was a national campaign. Not sure, people don't use, I want to say upwards of 60% of people utilize colonoscopy as screening, but those who are still using, fit cards, it's just another way of reminding them, making it easy for primary care, that sort of thing. And just a quick summary about what we've seen, some of the changes, an update in colon cancer screening in the last 5 years or so. Really getting away from what we call blood testing, going to FIT testing, with stool testing, along with Cologuard or stool DNA testing. Those two are the big change. CT colonography being endorsed. It's been used now for upwards of 10 years, but being more widely accepted. People really aren't choosing it for some of the reasons we talked about. Broader coverage for screening colonoscopy. That's been insurance-based things, no co-pays, that kind of thing. Those are always sort of fluxing depending on what's going on with legislation in various states, but also with the insurers. But there's been, in general, broader coverage considering this an effective way of screening people. Rising standards, and that's been a big push we've had in GI, is trying to identify and monitor our ability to detect adenomas. What is we have numbers we calculate every year as to how well we're detecting adenomas. Is it a high enough number? Are we picking up enough things that we should be picking up? That coupled with the quality of bowel preps, which is key, we monitor that closely. So we keep coming back to that. And we're always working on bowel preps to try to come up with better combinations for patients, but also to get a better look. These public health initiatives I mentioned. So what do? To reduce our risks, we follow testing guidelines, we know your family history, get regular exercise, don't smoke, not too much alcohol, eat 5 or more servings of fruits and vegetables a day, choose whole grains, limit your intake of red meat, maintain a healthy weight, basically general healthy living. That's the general gist of preventing colon cancer. Talk to your doctor, get tested if you're 50. Encourage your friends and family, don't be discouraged by the ick factor. Maintain a healthy lifestyle. So that's it.